morning, everyone. I'm Robert Stiles with Telehealth Rocks at KU School of Medicine. I'm really pleased to be offering this ECHO presentation today in partnership with the Department for Children and Families at the state, and really excited to have Dr. Leanne Jenkins and Dr. Sharon King joining us to discuss the medication guidelines that have been developed for use with children in foster care. And we're really excited to have everyone from such a wide variety of backgrounds, including pediatricians, people that work in foster care, people that work with mental health, people that work with school districts with us today. The way that today's ECHO session will go is we'll kind of spend some time going over the guidelines, and we'll talk about a few resources related to those guidelines. And then after that, excuse me, I understand it's hard to hear. Hopefully you can hear me a little better, and I won't be doing most of the talking, so hopefully the others will be better. So after that, we'll have some time to talk about the guidelines and a few examples and be able to take your questions. I'd ask everyone if they would please mute themselves during the presentation and only unmute yourself if you're asking questions. As well, you should feel free to ask questions in the chat throughout the meeting, and we'll get to those as we have time. And also after today's meeting, we'll send out information and other resources related to questions you might have, as well as a survey that we'd like you to fill out that will help us understand what else you'd like to know, how we can help to continue to provide information as we update the guidelines, or as there is more areas that need to be clarified or discussed related to the guidelines. I believe Dr. King will be starting the conversation today. If no, Dr. Jenkins? Well, I will go ahead and hand this off to the team, and we're really excited to have you today.
All right, we'll hand it off to Kelly, please.
Hi, I'm Kelly Hance-Reed. I am the Director of Medicaid and Children's Mental Health for Kansas DCF, and I'm really proud of the work that has gone into presenting this today and being a partner in trying to really improve the mental health outcomes of children in foster care. Youth in foster care are among the most valuable population in America today. On any given day, nearly 30% of children in foster care are on at least one psychotropic medication to manage their mental health issues. They're prescribed psychotropics 5 times more than the average children's Medicaid population. So let that sink in for a second. 5 times more. In fact, in 2018, a study by the Office of the Inspector General found that 1 in 3 children in foster care who were treated with psychotropics did not receive adequate treatment planning or appropriate medication monitoring. So when you have nearly 30% of children in foster care being prescribed psychotropics, and of that, 30% of those children aren't being monitored appropriately, that requires some additional oversight or assistance and support from all of us to ensure that they're getting the best quality care. So to ensure these vulnerable children who have experienced maltreatment receive the highest quality services, comprehensive services, this work group called the Psychotropic Medication Work Group was convened to address this issue, in addition to some information that came out from the Center of Medicaid Services and Informational Bulletin. So we formed this work group a few years ago to really address the issues that we're facing in Kansas. So we formed a collaboration with some generous psychiatrists, KDH&E, KDADs, MCOs, Kansas Kids Map, the University of Kansas, the child welfare case management providers, and DCF have convened to make a strong commitment to strengthen our system of prescribing and monitoring the use of psychotropic medication for children in foster care. This work group has met several times over the course of a few years to kind of review some of these things. And so the stakeholder group agreed to develop educational guidelines to support prescribing practitioners. We also agreed to have conversations with prescribers about this topic and share information that we might have that could be useful. We also committed to be proactive and implement a best practice approach to develop tip sheets and other opportunities to develop a deeper understanding of some of the issues at hand with this vulnerable population. All of this with the goal of decreasing the prevalence of psychotropic medication prescriptions among this population, but also enhancing the use of other evidence-based supports. So addressing the unique needs of these children who are experiencing foster care requires a multifaceted yet targeted approach. And psychotropic medications is just one component of this treatment. We really wanted to ensure that we are safely and appropriately managing psychotropic medication usage at the same time that we enhance capacity to implement effective non-pharmacological interventions, such as the use of evidence-based practices and therapies. Medications could potentially be an important component of some children's treatment, but also additional oversight of psychotropic medications is necessary in order to effectively serve the clinical needs of this vulnerable population. So a special thanks also goes out to the state of Texas. These guidelines that have been enhanced came originally from Texas. They've been using them there for years. And the feds use these guidelines and well, so they've been well validated and used and enhanced and improved over the years. So we hope you enjoyed this presentation today and find it useful. I would really like to thank that the work that this group has done, the hard work and dedication to this really important population of children. I would especially like to thank our presenters today who have really spent countless hours working on this initiative and really improving the treatment for children experiencing foster care. So with that, I am pleased to announce these two brilliant and dedicated doctors, Dr. Sharon Kane, who is the director of the Division of Child and Adolescent Psychiatry and the director of Child and Adolescent Psychiatry Training Program, and a professor at the Department of Psychiatry and Behavioral Science at the University of Kansas School of Medicine. Also, I'd like to introduce Dr. Deanne Jenkins. She's a child psychologist at ComCare Family and Children's Services, and she's also the chair of the Kansas Mental Health Medication Advisory Committee. So thank you all for being here today, and here's Dr. Kane and Dr. Jenkins.
Okay, next slide, please.
Neither Dr. Kane nor I have any relevant financial disclosures to share. Also, we do not intend to discuss an unapproved or investigative use of commercial product in our presentation. Next slide. The information and the recommendations involving clinical medicine is based on evidence that is considered currently accepted collectively by our profession.
Next slide.
Next slide.
Okay, good morning, everyone, and thank you to Kelly for the nice introduction. And again, want to say that this psychotropic medication utilization parameters for children and youth in foster care in Kansas is the culmination of quite a bit of work for our committee, and so we're proud to be presenting it. Next slide. But we want to thank other people that are responsible for it as well, and have given us a lot of help along the way, including Kansas Department of Child and Family Services and the entire Psychotropic Work Group Committee, the state of Kansas for sharing their parameters that have been in place for a number of years with us. And then we have a number of people both on the committee that also work for the state of Kansas in other capacities, and several people at the University of Kansas who also helped in this endeavor. Next slide, please.
So our psychotropic medication guidelines were originally developed in March of 2018. We did an update in 2020, and the guidelines are now available on the website of the Kansas Department of Children and Family Services as of January 2021. Just to give a little more background about these guidelines, why they were developed and how we got here. Kelly already referenced that the federal government has been concerned about the use of psychotropic medication in youth and foster care. There have been studies by the Government Accountability Office and the Office of the Inspector General of Health and Human Services on this matter. She referenced the increased number of psychotropic medications prescribed in the foster care population compared to the non-foster care Medicaid youth, and that when they did follow-up studies regarding the quality of care, they identified that 67% of the children who were being prescribed psychotropic medication in the foster care population had quality of care issues, either in inappropriate lab monitoring, too many psychotropic medications being prescribed, or the psychotropic medications were not being prescribed for the correct diagnosis. Subsequent to this, federally, the Department of Health and Human Services mandated that states develop oversight into prescribing practices in the foster care population. In Kansas, Dr. Becky Aikens did a study for our state to look at the degree of the problem that we were having here. And it was determined that we had a rate of 3 times higher prescribing in our Kansas youth in foster care compared to our non-foster care Medicaid population. So when the members of the Kansas Psychotropic Medication Foster Care Work Group got together to develop interventions, we looked at what other states had done. Education to medication providers seemed to be the cornerstone of what was successful in other states. We were particularly impressed with the state of Kansas, with the state of Texas. In the state of Texas, they've been doing this for more than 10 years. They've had good outcome data. They have a committee of 14, primarily child psychiatrists, that reviewed 119 references to develop their state's practice guidelines. In addition, the Texas guidelines were used in the Office of Inspector General study that Kelly and I referenced earlier. They used the Texas guidelines to critique prescribing habits. So very well validated. Texas did give us permission to adapt their guidelines for Kansas, and at least 95% of what we're going to be presenting today was developed in the state of Kansas and then adapted to fit the needs of our state. Next slide.
Okay, so at the introduction to the parameter, you will see a disclaimer. And the main point here is that these utilization parameters or guidelines for children, youth, and foster care are really intended to just provide some guiding principles for quality care for these children and adolescents who often present with very complex clinical pictures. The intention is not to present rigid treatment algorithms that are required to be followed. That is not the intent at all. And we don't mean for this to be something that replaces or supersedes the clinical judgment of the providers who are actually working with these children and really seeing firsthand what the situation is. So that is a very important point that we want to make sure that providers are aware of. Next slide, please. So online, you will see a separate document that is the introduction and general principles that appears as a separate document. And then the actual medication tables have the dosing and names of the medication. So in the introduction and general principles, you will see those guiding principles. And we're just going to do a quick review of those. Next slide, please. So in the introduction, you'll find a few points here. One is that before any psychotropic medication is prescribed, as with all children and adolescents, it's very important that there be a comprehensive evaluation and a physical examination done before any medication is prescribed. Also, it's important that non-pharmacological treatments should be considered and perhaps tried depending on the situation before medication is started. And it's also important to keep in mind that many of the psychotropic medications are not FDA approved for the use in children and adolescents. And so sometimes they are used off-label. Next slide, please. And the role of the primary care providers in treating these children and adolescents is also very important. And there's actually a document or an article by the American Academy of Pediatrics that is available online. And we can put the link to this in a chat so that you guys can access this later. And this article does talk about how valuable the primary care providers are. And in many cases in rural areas in the state, primary care providers are often the ones who are prescribing psychotropic medications for youth in general, and especially those that are in foster care. Often when children and adolescents change placements, it's the primary care provider who is prescribing those medications until children are seen by a mental health care provider. Next slide, please. And now we're going to go through some of those other general principles regarding specifically the use of psychotropic medications in children. Next slide, please.
Before psychotropic medications are prescribed, a DSM-5 psychiatric diagnosis needs to be ascertained. You don't want to just use a psychotropic medication to treat anger outbursts. You want to get more specific about what the underlying psychiatric diagnosis is. A comprehensive physical exam needs to be completed. This is to identify medical problems or issues that may impact your medication treatment. Target symptoms and treatment goals should be clearly defined. These target symptoms and treatment goals should be assessed at each visit, and it's preferable to use standardized rating scales to quantify the response of the child's target symptoms. Examples would be a Vanderbilt rating scale, a CGI rating scale, a GAD-7. There are many that are available that can help standardize. Next slide. It's important to consider the overall benefit to risk analysis. This is going to be different for every specific child, depending upon the severity of their symptoms, their medical history, their genetic vulnerability, and except in the case of emergency, informed consent should be obtained before medication is prescribed. This would include a discussion of the diagnosis, common side effects, more serious adverse effects, alternate treatments, and the risk of not treating. Next slide. Whenever possible, trauma-informed, evidence-based psychotherapy should begin before or concurrent with psychotropic medication. With preschool age children or under the age of 5, there should be more emphasis placed on treating with non-psychopharmacological interventions. This includes training parents in evidence-based parent management techniques. Medication management needs to be collaborative, involving the youth and caregivers. And where applicable, child-related agencies should be involved. Next slide. The presence of absence of side effects should be documented in the medical record at each visit. Appropriate monitoring of indices such as height, weight, blood pressure, and laboratory findings should be documented. This is considered standard of care. And then COVID came, and we shifted to telemedicine Zoom appointments. We thought it would last a month, and then it lasted 3 months, and then it lasted 6 months. So we are trying to get as close as possible to the standard of care with the environment that we're in right now. I find myself in my appointments asking more details about involuntary movements, since I'm not able to ascertain or visualize that over the phone. I will have parents buy a scale or a blood pressure cuff and try and log some of this information for me at home. My patients that are attending school, in building school, we're able to utilize school nurses to help monitor some of these indices. I don't know about you, Dr. Kane, but I find myself being a little more conservative about my medication choices and about the doses that I'm using right now with our current COVID environment affecting how we're practicing.
Exactly. Yeah, mine too.
But that is considered standard of care. So that's what we're presenting to you today. Next slide.
Okay, and monotherapy should be used or tried before polypharmacy. So in other words, one medication should be tried first before adding additional medication. So trying to find out, which is the main problem, what is the main diagnosis or causing the main difficulty, and really try to address that first before adding other medications. And when multiple medications are needed, it's really important to be systematic about it and add each medication, being sure that you're monitoring for side effects and documenting the reason and stopping any medications that don't need to be continued. And the goal is always to have children on the least amount of medications for the least amount of time. And when medications are started, they should be initiated at the lower end of the recommended dose and then titrated up slowly and carefully as needed. Next slide, please. And only one medication should be changed at a time, unless clinically indicated. If for some reason several medications need to be stopped because of safety, that's a different story. But in general, change one medication at a time, otherwise you don't really know what is causing what. And follow-up should be done frequently enough so that you can adequately monitor the response to treatment. And always monitor carefully for any emergent side effects, but especially suicidality, which can occur from some of our treatments, such as with antidepressant medications. And if someone is not improving in the time expected with a certain treatment, then do consider seeking consultation with a psychiatric specialist, with a child psychiatrist if possible, or a general psychiatrist who has had training with child and adolescent patients. And so I think, try to follow the children closely enough so that you can tell if they're responding in enough time. Next slide, please. And then another point, before adding additional medications to a medication regimen, think about other reasons they may not be responding. For example, is the patient actually compliant with the medication? Are they taking the medication every day? Is the dose appropriate? Is the diagnosis appropriate? Rethink that. Perhaps they've been misdiagnosed, or they've developed a comorbid conditions. Children are constantly growing and developing, and sometimes they might develop new conditions as time goes on. And do discontinue ineffective medications rather than just adding a second medication. Sometimes when we follow up patients and the parents say, this medication is just not helping at all, not doing anything. So don't just add another medication at that point. Go ahead and taper off before starting the second medication. Next slide, please. And now when a medication is being used for aggression that's associated with more of a behavioral diagnosis, such as oppositional defiant disorder or disruptive mood dysregulation disorder, be sure and reevaluate the necessity for continuing that medication, especially if it's an antipsychotic medication, which is often used for aggression in patients who are not psychotic. So it's important to not just start one of those medications and continue it over a long period of time, but at least every 6 months, reevaluate the need and stop it if at all possible. Or if it really is needed, then it's important to document the improvement and side effects and why it is needed. Next slide, please.
With the increased federal oversight with youth in foster care, the trend is currently for the use of PRN medication or as needed medication to be generally discouraged. When appropriate, using an antihistamine for anxiety or dystonia or other medication side effects is understood. When you do this, remember to give maximum dosages in a 24-hour time period as a limit on your prescribing. The important point here is that in the state of Kansas, we do not want medication to be used in the place of evidence-based psychosocial or behavioral interventions for youth in DCF custody. A standing order for the use of PRN medications for behavioral dysregulation outside of a treatment facility or without appropriate supervision by medical staff is strongly discouraged. Next slide.
Okay, and when you're treating preschool age children, it's very important to consider psychosocial or non-medication treatments first. We have much less data and information about using psychotropic medications in this age group. And there is an article or published guidelines. It's a little bit old now, it's from 2007, but it's still worthwhile referring to. And again, we'll put this references here. I guess it could be in the chat group too. But the Preschool Psychopharmacology Working Group, the PPWG, it's a lengthy article that reviewed the literature in the preschool group. And there are several algorithms in there that suggest what medication does have some evidence, and there isn't a lot more evidence since 2007. There's currently an ongoing study looking at amphetamine stimulants in preschool age children, which is not completed yet. But outside of stimulants, there isn't a lot. There's a little bit, and that this guideline does review that, so consider that. But it's really important to remember that we don't have a lot of good data in preschool age children, so it's really important to, when you're working with this age group, to really assess the parent and the parent-child interaction, to look at parent-child interactions, to look at therapy, behavioral therapy, like help train the parents with behavioral therapy and look at parent-child interaction therapies. And consider that for like at least 12 weeks first before considering a medication. And remember that when it comes to the antipsychotic medications, that we don't have a lot of information on how those medications are going to affect growth and development in this age group. So again, be cautious with medications. Next slide, please.
So the FDA distinguishes between a level of warning associated with medication adverse effects, as do we in the medication tables we're going to present. We have different columns for those. In the FDA product label, most of that comes from pre-marketing research. There's a warnings and precautions and an adverse effects section. But particularly significant are the critical adverse effects noted post-marketing. And these may be boxed. We call that a black box warning. This is the strongest warning required by the FDA. An example would be the potential suicidal ideation that can occur with antidepressants. These more critical effects are demarcated by a box at the very beginning of the product labeling. In our medication tables that we're presenting, there is a specific column for black box warning to draw the prescriber's attention to those more serious possibilities. We also want to note that the warnings and precautions column in the medication tables are not meant to be a exhaustive list of possible adverse effects. For that, you'd want to refer to the FDA's product insert. Next slide. The FDA requires that medication guides be issued with certain classes of medication. The FDA is taking additional measures to try and avoid serious adverse effects in the youth population. These medication guides advise patients and caregivers regarding possible adverse effects and include precautions that apply to that class of medication. And we put a link here to one of our favorite resources, copies of medication guides for psychotropic medications that are on the FDA website. Particularly readable for use with our families. Next slide.
Okay, and this this slide shows some of the information that are in the medication tables. The medication tables are in an Excel document that's linked separately on the DCF website, and we'll pull that up in a few minutes and go over and show that to you. And it refers to that here as the attached medication charts. But again, the tables are intended to serve as a resource for clinicians and are not necessarily intended to be comprehensive. Next slide, please. So not all medications prescribed by clinicians may be included in the following tables. And again, this is a disclaimer that in general, medications not listed do not have adequate efficacy and safety information. So you'll see that on a couple of the medications, we put that we didn't think they had enough information in the literature to support being recommended for use in children and adolescents. Next slide, please. So before we go to the tables, just wanted to give you a couple of resources here. The ACAP is the American Academy of Child and Adolescent Psychiatry, and their website has one link on it for systems of care resources, and I want to show you that. Next slide, please. Because they have some resources that I think would be helpful. Again, it's called Collaboration of Child Serving Entities. And there are a couple of handouts on there that I think are pertinent. And I got the link on the slide. Not if you mind going back to the other slide. I just want to show you what it looks like. Can you back up, please? There we go. And here's a couple of the handouts that link from that page I just showed you. One of them is called A Guide for Community Child Serving Agencies on Psychotropic Medications for Children and Adolescents. It doesn't like list the medications like we have in our tables, but it discusses some information for child serving agencies in the community. I think that's helpful. And then there's an update for 2015. So those two documents I would refer you to. Another resource that I think would be good for anyone wanting to know more information about medication, this parentsmedguide.org is an excellent website for, say, for foster parents who might want to know about medication that's being prescribed for children in their care. Next slide, please. And then one more slide. Sorry to jump around. And this is what that website looks like, parentsmedguide.org. And you'll notice here that there are different diagnoses here: ADHD, bipolar, and depression. So there are medication handouts here and guides that really discuss the diagnosis and then go through the medications and talk about potential side effects versus benefits of the medications and in some detail. And and they're listed in, they're available in English and in Spanish too. So those are helpful. That's a very helpful website. So if you don't mind going back 2 more slides to the resource slide again, if you don't mind. I had 1 more resource, sorry. Okay, and then 1 more resource here, primary care issues for children, adolescent, foster care, and kinship care at the American Academy of Pediatrics. This is 1 more nice resource. So these are all resources that we can put in the chat for you as well. Sorry, now if you don't mind going back, now I think it's 3 slides down. Sorry to jump around. Yeah, right there. Okay. So now what we'll do, and then here is I'll pull up the Excel spreadsheet and we'll show you the tables. And we'll kind of go through the highlights. But I want to let you know that we have a review committee at DCF, and the committee is made up of clinicians, mostly child psychiatrists and pharmacists, who will be meeting on a regular basis every 2 months to review the medication tables and guidelines, and looking for new articles, new information, new medications, and making any additions or subtractions, making any edits that need to be made. And as far as future directions, we'll be interested to see what ideas any of you have after today. But one thing we're thinking, based on what Texas has been doing and some other states that we've been looking at, is we're thinking that in addition to our tables, because right now the tables mainly give you information about dosing, how to monitor medications, and the warnings associated with them. But what we're thinking might be helpful in the future is maybe linking to up-to-date evidence articles that might help guide you about medication choice. So we'd be interested in hearing back from some of you or all of you about what thoughts you might have about that. So now I might go ahead and see if I can share the tables, and if that will work here. I can share my screen.
These tables were put together to try and be a quick and easy to use desktop reference. I think when you see how we have the medication guidelines formulated in terms of different classes of medication and different.
Can you see the tables? Okay. And you'll notice, so it's in an Excel spreadsheet. You'll notice at the bottom, you'll see here's the titles, the names of the tables. So there are in total 12 different tables. You'll see here ADHD stimulants page 2, other ADHD treatments, and so forth. There's 4 pages for ADHD treatments overall. So I'll start with, here's ADHD treatments. So the first page for ADHD stimulants has all the amphetamine products. The second page for ADHD stimulants has all methylphenidate products. And so to show you the columns up above, first we have the generic name. So you'll see amphetamines, amphetamine mixed salts. We'll have the brand names, initial doses. And this is max dosage based on the literature, max dosage based on FDA approval. And
I also like this FDA column because it's not only max dosages, but it tells you that it will give you the specific diagnosis that it has FDA approval for. Like, for example, Abilify, it has FDA indication for schizophrenia, for bipolar disorder, for irritability associated with autism. And for each one of those indications, there's a different age range. And it's next to impossible to keep all of that straight. So this table is a very good reference to know when you're prescribing off-label or on-label.
Good point. I can switch over to that in a minute. Now, the reason it doesn't have the diagnosis on this particular table is because these are all ADHD medications, so their approvals are all for ADHD. But that's a good point when we get to the antipsychotics, because they are approved for different things, for schizophrenia, for bipolar. I will show you that in a minute. So this is, and this column was added because maximum dose, this is Kansas Medicaid. So this, if this differs from what the literature says, then you'll see that. So that way you'll know what Kansas Medicaid max is compared to what the FDA says, compared to what the literature supports. This is the daily scheduling, like how many times it should be dosed. Jump in wherever you want to.
You know, some of our audience may notice there's a difference between the FDA-approved maximum dosages and the literature-based dosages. And that's because after a medication is approved for the use in youth at a particular dosage range, there's oftentimes more research that's done that expands our knowledge base. And so the literature-based maximum dosage column usually represents the expanded research that was later developed. Oftentimes, you will notice those dosages are a little higher than when it was originally approved by the FDA.
Right, and so I'll just, in the interest of time, I'll skip ahead and show some of the other tables. So the SSRI antidepressants, and you'll notice, oops, that on Paxil or paroxetine we reviewed, but we didn't include or recommend it because of evidence of possible harm in children and adolescents.
Right, that was one of the medications when they were trying to get FDA approval for youth, that suicidal ideation was identified, and that eventually led to the black box warning that we currently have. So I appreciate that that these tables not only give you guidelines to how to use, but when you may not want to use.
And then we have another newer medication that there just doesn't seem to be enough evidence yet in use in children. And then let's see, go along here to the other, maybe show one of the atypical antipsychotics. And then if anyone has any questions, feel free to put questions in the antipsychotics. And then we may want Polly Freeman to jump in, because there's a great program at KU Wichita that can be very helpful.
Someone has asked, where do we access these tables? We mentioned earlier on the Kansas DCF website, there's a link to the narrative that we went over, and then there's a separate link for these tables.
And maybe we can put it in, maybe Christy can put it in the chat. Yeah.
Yes, it's been included in the chat, and we will send out all of the references and resources as a separate document as well after today's session.
And I think I've done something to the tables here. I can't seem to get to the antipsychotic tables in this.
To answer the question about the medication tables more specifically, on the link, the tables are identified as the Psychotropic Med Utilization List for Kansas foster care. And that gets you to these tables. It's a very, the tables are very extensive, have a lot of very useful information that you can access very quickly. And of course, you could also print them off.
Okay, Polly, do you want to talk a little bit now about your program, Kids Map program, just so people know about that before we run out of time?
Sure. Is somebody able to show the slides? If not, I can do without slides too. I just want to say thank you to Telehealth Rocks for allowing us to present our program. We are a HRSA-funded program in partnership with Kansas Department of Health and Environment, KU Psychiatry, and KU Pediatrics. And some of our enrolled physicians are on this ECHO today. We're a pediatric mental health access for providers in primary care across the state of Kansas. Our pediatric mental health team includes 2 board-certified child and adolescent psychiatrists, Dr. Brown and Dr. Chicolari McCaldy, and a board-certified child and adolescent psychologist, Dr. Klaus, board-certified pediatrician, Dr. Carrie Harris, and myself, a licensed social worker. We have 3 components to our program. PCPs can call or email the consultation line for mental and behavioral health, as well as community resources, or they can request a consultation with our pediatric mental health team. Some examples of requests just recently we've received. I had a call from a psychologist for information for adoptive parents who have a child with prenatal substance exposure. I was able to share information on parenting as well as some tip sheets for classroom teachers. Another request this week was from a psychiatrist who wanted resources for a parent with a child with complications of a medical condition. They wanted help with CDDO, insurance, and other resources for their teen with complex medical needs. Most of the time, our consultations with the pediatric mental health team are for medication. We find that simple questions end up being answered with complex answers. We offer a biopsychosocial approach with resources tailored to specific recommendations. The second part of our program is the TeleEcho Clinic. It's an ongoing virtual clinic that meets twice a month over the noon hour for case-based learning and a didactic focus on mental and behavioral health diagnoses and treatment. Our last component is physician wellness. As you all know, working in the foster care system, treating and caring for children and families with behavioral and mental health needs can be very taxing. We have several resources we share with our enrollees. Later this year, we're offering a workforce wellness program designed for entire clinics, as well as a virtual wellness retreat and wellness kits for our enrollees. Space is limited for the virtual wellness retreat, and more information will be coming soon. In the last year, we have recruited over 100 physicians and clinicians and completed over 175 intakes to the consultation line. The blue spots on the map indicate where our enrollees are located, and the larger the circle, the more enrollees, more enrolled providers there are in that area. So we are still actively recruiting. As you can see, there's holes in the state. We would like to increase our enrollment. So if you are in rural areas or even in urban places and you want to connect physicians or clinicians to our program, we would more than welcome that. Enrollment is free, and we would love to serve you in your practice. And there's my information for the contact.
Thank you. I was able to pull up the DCF website, and if I can share my screen again, I could show people want to see how to connect.
Sure, you should be able to. If not, let me know.
Okay, we'll do that quickly here.
Dr. King brings that up. Just a reminder, please type in your questions. We'd love to hear from you.
And I think we will actually be able to answer questions from the chat. And Robert, maybe you can explain, we'll how will we be answering people's questions? You're going to collect questions from the chat. How will we address them later?
We will. So after today's session, we will be taking the chat as well as the PowerPoints and reviewing that and send out all of the resources that are referenced, as well as more information about how to access the guidelines and the tables and everything that we discussed today. In addition, any questions that have come up during the chat or that come up during the discussion for the next few minutes, we'll address as well and be able to send all of those out after today's session. So you are welcome to type a question into the chat, or anyone can also just unmute themselves and ask any questions that you have about the guidelines themselves or about Kansas Kids Map or anything that has been discussed today.
Okay, I might quickly, if you can see my screen, just quickly show you, here's the DSF website. This is the link. I don't know if the same one on the chat is the one we had on the slide, but you can see from the DSF website the services and partners. And then here's psychotropic medication utilization parameters right here. So you click on that. And then you'll see three, here on the bottom, you'll see the introduction and general principles, which we kind of went through, highlights from that. You'll see our review panel. So if you want to pull up the names of the people who are on the review panel, and then here's the actual Excel spreadsheet with the medication tables. So I'll pull that up. Let me get my computer to cooperate here. Still pulling up. Trying to. But yeah, and so here's the tables at the bottom there. And here's yeah, here's an example of the antipsychotic tables. One of the questions I did see quickly had to do with EKG monitoring. I don't know the question in general. I think one was asking about maybe citalopram and some of the other SSRIs. I don't know, Dr. Jenkins, whether you want to say anything about that.
Well, I think with citalopram at the higher doses, that's a current recommendation because of QTC prolongation. And what I like about the tables is those kind of details that that one may not have committed to memory, but know enough to look it up can be found in these tables.
Right, and I know for us, I don't know of any, I don't think there isn't any requirement for fluoxetine or citalopram, although it's a good point that citalopram was not known about until it had been used for a while. So some people may be cautious about escitalopram, but as far as I know right now, there isn't any monitoring recommended for escitalopram, but only for citalopram, at least at 40 milligrams or higher. We are not using it very commonly with children and adolescents, but probably would do EKG monitoring in children when using that.
And the patient monitoring parameters column very helpful in regards to lab monitoring. It's different for different medications. Those are the kind of details that are sometimes hard to keep straight. It's very easy to find in these tables.
Right, and I think we have, let me see if I can get an example here. Yes, so we have I think we have our monitoring here. Baseline EKG and is recommended there. And fasting, so your metabolic monitoring is recommended baseline and then at 3 months. I think that's pretty standard for the atypical antipsychotics, and then annually after that. Any other specific questions? Oops.
I saw a question that came up from the chat from a school social worker who was asking a question about what to do when a child in foster care when it appears their medications aren't working. From the school's perspective, how to what action to take. And as a prescriber, I find it very helpful to get feedback from the school, very specific feedback, and some of those standardized rating scales that we discussed earlier can be useful in giving that feedback. A Vanderbilt is very easy to Google and have a teacher fill out. It reviews ADHD symptom control, oppositional defiant disorder, conduct disorder, anxiety, depression, and then adding a specific letter to communicate to the med provider about what they are seeing in the classroom in regards to timing of problematic behaviors or other things that they think the med provider should know. As long as there is an adequate release of information, that would be the kind of information that would help really round out the picture for the prescriber. Dr. Kane, do you have any more thoughts on that question?
That's a great idea. And I wonder if we could include or send a Vanderbilt in the chat, or a link to Vanderbilt in the chat, so that people would have that. So it's a rating scale for ADHD that can be very helpful. Yeah, and it is free in the public domain.
Mm-hmm.
That could be very helpful. So
It helps identify the symptoms and quantifying them in a way that's meaningful to us as prescribers.
Yeah, we use those quite a bit and ask for people to send those. So I think that's a great suggestion. I think that would be very helpful and very welcome by the prescriber.
The other thing is there might be side effects that the teachers see in the classroom that a resource parent can't isn't able to report. They may not see the sedation in the afternoon, but a teacher could communicate that to us and really help guide how we're prescribing medications.
It's possible the medication is only given on school days and it's worn off by the time the child gets home. The parents may not be seeing it.
Exactly.
Well, we want to thank everyone for their presentation today and for this conversation. So we will be sending out a survey afterward to ask if there are still areas of concern or confusion that you would like to see further addressed in perhaps an additional meeting. And then in the future, we do plan to continue to have these sessions, especially as there are updates to the guidelines or significant changes in order to go through them. You know, I really appreciate the wide variety of people that we had participate today. I think we saw from the question about a school setting that, you know, our goal would be with any child to have everyone who interacts with that child be involved in the care and be communicating. And we know in situations where children aren't in foster care, it's difficult enough to have schools and parents and home and medical providers and behavioral health providers all communicating and involved. And then with foster care, you have an additional component that adds to difficulties. So we hope that you found today's sessions useful, both those of you that are medical providers, as well as those that work with children in foster care, that provide behavioral health services. And we look forward to working with you in the future. Dr. Evelyn Nelson, who's head of Telehealth Rocks and Can Do, if you have any final words, we really appreciate everyone being here today.
No, I so much appreciate the scope of what was covered and really hearing how both the guidelines work and the Kansas Kids Map really complement one another. It just seems like a real asset that we have in our state.